It's really exciting to be able to share with you some of our results, and specifically the results here in WA. And that's why we put WA Leads the Way. This is actually an international observational or prospective study that was actually led here out of WA. So that's kind of really exciting for us to be involved with. What I wanted to talk with you about today was to really just briefly review the study backgrounds and aims. In fact, I had to do this last night because I'd kind of forgotten, because 5 years ago is a long time. So it was good to review background and aims. And I want to share with you some of the interim results with a focus on WA. And just very briefly, I know Marnie alluded to this, was really looking at knowledge translation, or what do we look for in terms of the implications for policy change, and possibly here in WA with respect to pressure ulcer prevention and early identification and treatment. So without further ado, I want to introduce you to the study that we've been involved with over a number of years now, and it's called the OZCAN Risk Assessment for Sitting-Acquired Pressure Ulcers. Pressure ulcers are not a sexy topic in medicine, and they're certainly not a sexy topic in spinal cord injuries. They don't get a lot of playtime at the international forum. They certainly do at ANSCOS, and we really appreciate that. But nevertheless, they have a tremendous impact on quality of life for this group. We started off with some seed funding from the Fremantle Hospital Medical Research Foundation. We went on to secure an NHMRC grant along with Ontario Neurotrauma Foundation funding, and then added the Rick Hansen Institute for our site in Quebec in Canada. So everything was translated into 3 languages, apparently. That's Australian English and Canadian English, and then French Canadian. So we have 3 languages happening. Really, just talking about sitting-acquired pressure ulcers, they're really a subset of pressure ulcers. For those of you that may be new to the area of pressure ulcers, they're also called pressure injuries here in Australia. And they're involved, really it's about all the pressure ulcers that are involved happening on the pelvis. And you can see on the right-hand side, this is a left ischial tuberosity wound, that this one happens to go right through to the bone. It's a very high incidence in spinal cord injuries, between 23 and 33%. So 23 to 33 people out of 100 get a new pressure injury. And over a lifetime, it's a pretty scary probability that you're at 85% in the literature for actually developing a pressure ulcer. Why did we want to look at developing a new risk scale? Well, really, we wanted to be able to identify high-risk individuals. And what we found in the literature is risk changes over time. So as we age, not surprisingly, so does our risk. That's one good example. But what also we found in the literature is risk is very multifactorial. So, and we have some new contemporary risk factors that we wanted to be able to put to the test and see if they actually could add to the model. And we wanted to then be able to take some of those risk factors that we can in fact change and be able to identify them and modify them. There are existing risk assessments that we use. The Braden, Norton, Waterlow have never been validated really on spinal cord injuries, so they're not really good tools for prediction. There was an SCI specific tool, although it doesn't include some of the contemporary tools that we have now, and we wanted to be able to update and see if we could improve on that. This is essentially 2 studies that are back-to-back. So part 1 is really to identify those factors that are associated with a sitting-acquired pressure ulcer following spinal cord injury. And then to eventually develop a risk assessment tool to identify those that are at high risk. It's a prospective study. All spinal units in Australia were invited. 3 are actually engaged presently in the study. 5 spinal units in Ontario, Canada, and we did add 1 in Quebec. We had a very ambitious, you've heard all day long about the ambitiousness of recruitment and the much needed sample sizes. We needed 240 subjects that were new spinal cord injured, and then 240 that were chronic spinal cord injured. And we did 3-year follow-up, so these individuals were actually telephoned monthly, assessed on a regular basis. And I want to just acknowledge this could never have been done without individuals that actually signed up for 3 years for our project. And we owe them a great deal, actually, because it's a big commitment to be followed for 3 years. What factors did we collect? We did demographic data. We've talked a lot about it today, the ASI score, the FIM. We looked at body mass index. We looked at waist circumference, cumulative sitting time. We looked at bowel and bladder. We looked at quality of life. We did what kind of comorbidities. Do you have diabetes? Do you have heart disease? We also took sputum samples, and we're looking at polymorphisms in the genetic markers. We did blood tests as well. And we actually added and developed some of the protocols that were contemporary. So we we've developed a protocol for looking at interface pressure mapping. So we do that with the individual on their wheelchair cushion in their own wheelchairs. And this is an example of the output. We also developed a protocol to be able to measure parts of their posture. We felt in the literature and clinically that was very important to be able to do. So we've done that, and that's a contemporary and very new factor to look at. And there were many others. For example, we do ultrasound on the soft tissues overlying the ischial tuberosities, and that was a new protocol to be able to do as well. We do have a psychiatrist who specializes in spinal cord injury on as a chief investigator, and we couldn't get away without looking at really some of the psychosocial factors that may be associated with the development of a pressure ulcer. So we administer the Murong self-efficacy scale, anxiety and depression, a substance abuse questionnaire, and we look at the living environment and the support and access to equipment. Once someone develops the endpoint, which is actually a sitting acquired pressure ulcer, they essentially move to a second study, which is connected to Part B. And we have 2 health economists, one from Canada and one from Australia, and they've developed a cost diary. So we actually collect the costs and services associated with a sitting acquired pressure ulcer, and up until when the wound or the pressure ulcer closes. We also measure their health, the loss of health-related quality of life, which is really important for health economists, as we be able to quantify not only how much does something cost, but what does it cost to the person as well. Drum roll, here are the interim results. So you are the first to see some of the results coming out. They're very preliminary, but they're very interesting, and we're really excited to share those with you. So in Part A, we had recruitment of 21 participants here over the last 3 years here in WA, and I just want to walk you through some of the highlights. Like our other pilot study, we have actually a relatively high mean age in our study at 47, and we've had that consistently when we looked back at some of our pilot data. Not surprisingly, the gender is certainly in favor of males, but when you move down to body mass index, if we use the criteria right now for able-bodied, where 25 is the cutoff for being overweight, we're really almost there, if not there, when we take the median. And we have a cohort of acute where they had to actually be on the unit, so they're brand new people with spinal cord injured that are just getting sitting up. So half of those, 11 of those were acute that we followed during the study in Part A, and 10 of those were chronic, and the chronic meant really, in our inclusion criteria, you had to be at least 10 years post-injury, and you needed to not have had a medically serious pressure injury, which would have meant really a surgical intervention. The level of injury, we had half and half, although we just haven't finished our data analysis here, but half paraplegic, half tetraplegic, and a variety of AIS levels as well. Small sample size, but we reached 7 endpoints, which indicates an incidence of 33%. Which is we'll talk about that later. 4 of the new recruits from the spinal unit began walking, so they reached an endpoint, and we have 10 participants that are still active and being actively followed in the study. This is a very busy slide, and let me walk you through it. What I want to talk to you really is about the endpoint data and the services that people got, because I think that's what's actually really, really important with this data. So on the left-hand side, you'll have a list of the 7 participants. When you look to the next column, all of them had open wounds. So you can have actually a closed wound, like a bruise is considered, there's criteria for having a bruise or a closed blister. But all of them had open wounds. And the locations were all on the buttocks, but they were in the coccyx or sacrum, which is kind of the small of your back, or below the small of your back, just above your butt. Certainly the ischial tuberosities. One large area that we were told that was quite prevalent here is on the posterior aspects of the femur, but we didn't see those in these early detected wounds, which is interesting. When you move to looking at what the size or the area in square centimeters, there was a great range. So it ranged from 0.2 centimeters square up to 9 centimeters square. This is a standardized protocol that we use for measuring the wound when it was detected, and we also did a standardized depth assessment. What this indicates is there's actually a severity scale for pressure ulcers from 1 to 4, and these all indicated quite a homogeneous group of stage 2 and 4 being the most serious. So these are actually quite not so serious wounds. However, when you look at how many days did it take to actually reach the end point, so for those individuals, how many days in the study did it require them, or were they in time to reach the end point, that really ranged. So from 84 days up to 797 days, and it took a mean of 441 days. So really not a long time in the lifetime over people does it actually take, did it take these people to actually reach an endpoint, which we'll talk about later. This is, for us, the most interesting column is the number or time taken for the pressure ulcer to heal. So keep in mind that these are low severity pressure ulcers, and they range from 66 days to 352 days, so an entire year, or almost an entire year. And what was really interesting is when you start drilling down and looking at some of these, is here's participant number 1 who had a relatively large, relatively to the rest of the group, large pressure ulcer, and he only took 66 days to actually heal. That's still 3 months, and oftentimes individuals are told to get off their butts and go to bed and offload. So you can imagine just being 3 months offloaded to try to heal a wound. However, when you look at participant number 2, they had a really quite small wound at 0.3 centimeters square, but their time to heal was 352 days. I kind of took a gulp when I saw that. That's a long time to be healing a wound. So we wanted to drill down in our cost diaries and have a look at what else was happening. That's when we went to our Part B data. Now keep in mind, we have 7 open pressure injuries or pressure ulcers. We have the days to heal was 228. But we found out that 5 of our participants actually had treatment, professional treatment for their wounds, but 2 of them had been assessed professionally but had not been provided treatment. So they had no wound care treatment for that time period. None of them that actually had treatment ever had treatment until the wound was closed. So it took a total of 228 days, that was the mean, for their pressure ulcer to actually be closed. But treatment stopped halfway through at 102 days.